Hello everyone. Today I am going to talk about adenoid cystic carcinoma. Coming to the introduction, adenoid cystic carcinoma is an uncommon malignancy of salivary gland which is characterized by slow growth kinetics and perineural invasion, and it is a most rarer tumors for which there are few treatment options for patients with advanced disease. And according to Armed Force Institute of Pathology, adenoid cystic carcinoma is the fifth most common salivary gland neoplasm. So coming to the history, in 1853, Robin Lorraine and Labolibin first described two cases of uncommon epithelial tumors of nose and parotid. In 1856, Billroth named it as cylindroma because of its histopathological image. And in 1930, the term adenoid cystic carcinoma was introduced by Spice. Till 1943, they thought it is a benign lesion, but in 1943, Dockery and Mayo proved that it is a malignant lesion. So clinically, this lesion represents 10% of salivary gland tumors and 1% of all head and neck malignancies. It is considered to be the most common malignant neoplasm of submandibular gland and minor salivary gland. And the fifth and sixth decades are the most commonly involved age, and many studies proved having a female predilection. So the lesion starts with a local pain and facial nerve paralysis in case of parotid tumors, and fixation to the deeper structures and local invasion. Some of the lesions, particularly in intraoral ones, exhibit surface ulceration, and there may be clinical resemblance of pleomorphic adenoma in some cases, and it is having a marked tendency to spread through perineural spaces and usually involves well beyond clinically apparent borders. So gross findings, it's like the adenoid cystic carcinoma usually present as a very well-defined mass within the substance of the involved gland. On cut section, the tumor lacks encapsulation, although it may appear to be demarcated from the surrounding salivary gland tissue. Close inspection typically shows infiltration into surrounding tissue. The tumor is firm, white or grayish white, and is not usually cystic. Histopathologically, this lesion is having a three distinct architectural pattern. First is tubular, second is cribriform, and third is solid. And this lesion show a variable mixture of two or three patterns with prevailing architectural pattern determining the category. The first one is a tubular pattern. It is characterized by the tubules lined by luminal cells enclosed by the non-luminal cells with usually clear cytoplasm. And the second one is cribriform pattern. See the histopathological image. This is the most frequent type of pattern of the disease which will occur in a female in the case of 5th to 6th decade of life. And it is composed of basaloid cells organized in round or oval masses of variable sizes, punched out by rigid oval cyst-like spaces, that is pseudolumina. And those cells will have occasionally small true lamina lined by luminal cells composing of a Swiss cheese appearance. And the third one is solid pattern. It is having a worst prognosis, and it is composed of only basaloid cells. There will be no kind of luminal areas you can see here. And all variants can show a prominent perineural invasion, and the tumor can follow the course of nerve for a long distance. The neoplasm can also show intraneural invasion, considered an independent negative prognostic factor. The most common sites of metastasis are lungs, followed by bone, liver, skin, breast, and rarely the brain. And immunohistochemically, these are all the markers you can use to find whether this lesion exists or not. And especially in 1988, Chen et al. Divided adenoid cystic carcinoma into two histochemical groups. And the first group, which was found by Chen et al. In 2009, it was responded. Then the perineural invasion seems to be correlated to expression of S100 and glial fibrillar acidic protein, and c-KIT, C43, and VEGF and AGR. These are all the pictures I mentioned here for the IHC stains. And the differential diagnosis is very important to diagnose a lesion. And most lesions will have various differential diagnosis, depends on the histopathological image. And one kind of the thing is, in adenoid cystic carcinoma, the polymorphous adenocarcinoma may contain areas that resemble like this, but hence that is having the tumor which tends to occur in accessory glands has affinity for involving smaller nerves, and the tumor cell do not form as well developed ductal structures as seen in adenoid cystic carcinoma. And the second one is the salivary ductal carcinoma. Here you can see a differentiating factor histopathologically. See, this is called comedo-like necrosis. You can see in salivary duct carcinoma, not in adenoid cystic carcinoma. From that, you can differentiate both the lesions. And some benign lesions also, sometimes it will mimic adenoid cystic carcinoma, for example, canalicular adenoma and basal cell adenoma. The maze-like thing, what I mentioned in the picture, that kind of the cellular arrangement is not seen in adenoid cystic carcinoma, only in canalicular adenoma. And this is the basal cell adenoma. It shows a palisading nuclei at the periphery, and the tumor is typically well encapsulated or demarcated and shows no infiltrative growth pattern as seen in adenoid cystic carcinoma. And the treatment option is both surgical and radiotherapy is the best treatment option for adenoid cystic carcinoma. In general, this tumor is slowly growing lesion which tends to metastasize only late in its course. So better survival is observed in females, younger patients, and patients with localized disease at the time of diagnosis. And systemic chemotherapeutic agents also used for the treatment of adenoid cystic carcinoma. And the prognosis depends on the time being, and many studies, they have mentioned the prognosis is just the mortality, that mortality rate of the patient is decreasing in that when the time increasing. And the presence of tumor-free surgical resection is also a prognostic marker for a good prognosis in case of adenoid cystic carcinoma. And according to D. Angelis, he found in the follow-up of 5, 10, and 20 years of adenoid cystic patients, the survival rate decreased to 92 to 54%. As in seen in bandwidth also, it is reduced to 28% in 15 years, respectively. So the recent advances in radiation therapy, what they are giving for adenoid cystic carcinoma, the neutron radiation treatment, it is a very unique type of radiation. It is currently available at 2 medical facilities in the United States. And here they are using high linear energy of neutron beams, having the capacity to damage both the strands of DNA. This making it harder for the cancer cells to repair the damage. The relative biologic effectiveness of adenoid cystic carcinoma regarding neutron radiation treatment is 8, and this is the mission. And see that this means that treating adenoid cystic carcinoma with 2000 neutron centigrade is equal to using 16,000 centigrade of photon radiation. Here you can reduce the radiation also. Here you can save some kind of best tissues in and around the lesional areas. And in photon radiation, it causes cellular damage by producing free radicals, which depends on oxygen, but in neutron depends less on oxygen and cause cell death by direct interaction. Thank you. I hope you can understand this.